Welcome to this webinar on applying motivational interviewing in suicide risk assessment. My name is Jonathan Kratz. I'm a clinical associate professor in the Ann and Henry Zero School of Social Work at the University of Oklahoma. I'm also a member of the Motivational Interviewing Network of Trainers. The Suicide Prevention Resource Center at the University of Oklahoma Health Sciences Center is supported by a grant from the U.S. Department of Health and Human Services, the Substance Abuse and Mental Health Services Administration, and the Center for Mental Health Services. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, and policies of CMHS, SAMHSA, or HHS. The Suicide Prevention Resource Center is the only federally funded resource center devoted to advancing the implementation of the National Strategy for Suicide Prevention. SPRC builds capacity and infrastructure for effective suicide prevention through consultation, training, and resources for state, tribal, health, behavioral health, community systems, professionals, professional education programs, and national public and private partners. In this webinar, we will explore how motivational interviewing can be used as a valuable tool in suicide risk assessment. We'll begin with a primer on motivational interviewing, outlining its core principles and techniques. Then we'll look at hope theory as a useful theoretical link between motivational interviewing and suicide risk assessment. Finally, we'll map motivational interviewing to suicide risk assessment strategies. To start, let's explore a brief history of motivational interviewing and the emerging literature on how it has been used when working with clients who are also experiencing suicidal thoughts and behaviors. The Manual for Motivational Interviewing, or MI for short, is in its 4th edition, and the framework is supported by over 40 years of research, with over 2,000 controlled trials and over 200 meta-analyses and systematic reviews. While early research on MI focused mostly on substance misuse treatment, the framework has proven effective in a wide range of client challenges, including with clients who are experiencing suicidal thoughts and behaviors. The literature on MI in suicide prevention shows that it significantly increases client engagement in services. It enhances means restriction counseling, increases adherence to safety plans and follow-up care. It's a promising short-term or bridging intervention between risk assessment and further treatment, and it has been shown to actually enhance outcomes when integrated with treatment as usual. Given all this, it's no surprise that there's growing interest in exploring how MI can be applied in suicide risk assessment, or SRA for short. But before we dive into how MI can potentially enhance risk assessment, it's helpful for us to pause and consider some of the common challenges clinicians encounter during traditional SRA processes. First, there's the issue of implicit power dynamics. Traditional SRA can sometimes feel like an interrogation and unintentionally reinforce an authority-driven dynamic where we are asking all these questions and the client is left feeling like they're under a microscope. And when things like hospitalization are on the table, clients may worry about losing their autonomy, and that fear can limit their openness right when we need it most. There are also concerns with the pathology-centered focus of many SRA models. Risk assessments, by design, center on clients' thoughts, plans, and intent around suicide. And of course, we need to understand these things. But when the focus is too heavy on risk and warning signs alone, something else can happen. That deep focus on what we'll call death talk can unintentionally deepen a client's sense of despair. Another area of concern is the impact of the fixing reflex in SRA. This one's a little tricky because it's so natural when someone is in crisis for us to want to help. We want to offer solutions. We want to fix things. But when we move too quickly to solutions before a client feels truly heard, it can feel like we're taking control. And when that happens, clients may reassert their autonomy by resisting or even rejecting our suggestions. So this rush to fix the problem can make clients feel like we're minimizing what they're going through. And this can feel dismissive and like we're not really listening. Finally, there's the issue of therapeutic misalignment. A client in crisis is rarely seeing us just because of their suicide. More often than not, it's about the pain, despair, and feeling trapped. And if we focus exclusively on suicide risk assessment, we may miss this broader distress driving their crisis. And this is where motivational interviewing comes in. It offers a framework that can help us potentially address many of these challenges in SRA. And just to be clear, I'm not saying that motivational interviewing can replace SRA. Risk assessment is absolutely essential and non-negotiable in many cases. But MI can be a useful framework for thinking about the lead up to an SRA, potentially helpful during the assessment itself, depending on the model, and it's definitely valuable after SRA. It's not about replacing the work of risk assessment. It's about enhancing how we engage with clients throughout that entire process. So MI is less of a standalone approach. It's more of an evidence-based way of being with clients that can complement other models. In the MI text, Miller and Rolnick discuss this principle as it applies to integrating MI with other treatment models like CBT, and what I'm suggesting is really no different. That MI can enhance many of the tools we are already using with clients experiencing suicidal symptoms, like the Columbia Suicide Severity Rating Scale, or QPR, or the suicide status forms used in CAMS. What I'm suggesting is that MI can be a way of doing SRA. So before we get into the weeds on how MI might fit into SRA processes, I want to pause and offer a quick refresher on what exactly MI is all about. Motivational interviewing is defined as a particular way of talking with people about change and growth that strengthens their own motivation and commitment to make changes in their life. And beyond this technical definition, I think it's interesting to look at how clients who receive MI interventions often describe that experience. And what we see is they use language that essentially boils down to, this was a good person to talk to. This was a person who was helpful to me. And that's exactly what we want clients to feel during an SRA. So this is a model that's been applied in countless different settings with a broad spectrum of different client problems. And the reason it's effective in so many different contexts has less to do with the specific practice area or client problem, and more to do with the fact that MI is helpful in most situations where a client is ambivalent about a change in their life. In MI, we conceptualize ambivalence in terms of the language we hear from our client: sustain talk and change talk. When a client expresses reasons not to change, from an MI perspective, we don't really see them as resistant. They're just sharing their sustain talk. And it's our job to understand what's on the other side of that coin, the change talk, language that reveals the reasons for change. And this concept of ambivalence is really central to MI practice. Think of ambivalence like an unfair football field that's built on the side of a hill. The team trying to score going downhill has a much easier time than the team trying to score going uphill. You could simply lay the ball down and let it roll down the hill on its own. It's much easier to not change than it is to make a change. And the status quo has a lot of power. And one of the challenges with our clients is that when they are stuck in a state of ambivalence, this conflicted state has the default outcome of not changing. If I'm super ambivalent about getting up at 6 a.m. to go to the gym, there's a pretty decent chance I'm not going to go to the gym. Skipping a workout is really easy. I can literally do it in my sleep. So the idea with motivational interviewing is that through intentional conversation, we can try to level this playing field. We can be deliberate in how we interact with clients around their change talk and their sustain talk, giving them the opportunity to make decisions based in their values and priorities. And this is a key element of MI. It's very focused on the language we hear from our clients. When clients are ambivalent, they, as we've already said, naturally express both sustain talk and change talk. And in MI, we listen carefully for these verbal cues, particularly expressions of desire, ability, reasons, and need as they relate to change. Some statements will pull towards the status quo, reinforcing why staying the same feels safer or easier, while other statements move forward towards change. signaling motivation to do something different. Our role isn't to force change, but to help clients explore these competing internal forces, creating a space where their own motivation can emerge. But MI isn't just about what we listen for, it's also about how we guide the conversation. It's a structured, collaborative process that helps clients work through ambivalence while we are still honoring their autonomy. And this is where the model is significantly more directive than you might initially think, through 4 fundamental tasks. Think of it like a staircase, with 4 steps that build on one another to support change. This is essentially a modified version of the generalist practice model that we use in most clinical practice settings. Engagement is the establishing of a relationship with the client. Focusing is identifying a specific behavior change to guide the conversation. Then we use evocation, where we have clients verbalize their own change talk. And finally, we do planning, where we develop plans for next steps. And it's important to think of these tasks as a staircase that we climb with our client, one step at a time and in order. This matters especially in SRA, where we may have a temptation to jump straight to the top step, to planning, before we've built a relationship with our client, before they've even decided whether they want to have this conversation with us at all. Skipping steps can leave clients feeling rushed, unheard, and even resistant. And of course, following these MI tasks isn't just about technique, it's about how we show up in the conversation. The structure works best when it's grounded in a particular way of being with clients. And that's where what we call the spirit of MI comes in. It's not a checklist, it's a stance, a relational framework that guides how we engage, how we listen, how we respond. In MI, this relational framework is called the spirit of motivational interviewing, and it has 4 distinct elements: partnership, acceptance, empowerment, and compassion. Let's go through them real quickly. Partnership is a stance where we are on equal footing with the client. This isn't about stepping down or giving up authority. It's about recognizing that clients have pretty much all the power when it comes to behavior change. And we are really asking for permission to work alongside them. Partnership is about asking the client to share some of their power with us. Acceptance means honoring the client's autonomy, their right to make their own choices. And most clients don't use words like acceptance to describe what it's like to receive motivational interviewing. When we embody a spirit of acceptance, clients describe this experience as one where they feel respected. And that really matters. Ask yourself, would you rather conduct a risk assessment with someone who feels respected by you or someone who doesn't? Next up is empowerment. And this is about drawing motivation out of the client rather than trying to impose it. You can gift wrap motivation and hand it to somebody, but that's not really how it works. The real power comes when clients hear themselves say what matters and why it matters. Our job is to create the space for that to happen. And last but not least is compassion. This is about showing up with real, authentic care. Clients can tell when we're just going through the motions, and they can feel when our empathy is surface level. But true compassion builds trust because it comes from a place of genuine interest and concern. When we approach clients with authentic compassion, we naturally create an environment where genuineness thrives, an environment where a client feels safe enough to open up and explore their ambivalence. And so that's the spirit of motivational interviewing that gives us a mindset or a way of being with clients. But we still need tools to carry this out, and that's where the technical skills come in. In motivational interviewing, those skills are captured through the acronym OARS, which stands for Open Questions, Affirmations, Reflections, and Summary Statements. And to be clear, these aren't new skills. They've been part of good helping conversations for as long as we've had language. What makes MI different is how we use them deliberately, with purpose, to support change. And so it's the skillful use of these concepts that makes MI truly come to life. When we engage with clients who are ambivalent about change, approaching them with the spirit of partnership, acceptance, empowerment, and compassion, using basic clinical skills like OARS, we guide the conversation through engagement, focusing, evocation, and ultimately planning. And the theory of MI is that when we increase change talk, the client's verbal expressions of desire, ability, reasons, and need to change, that this directly relates to behavior change. In a similar way, when we help diminish sustained talk, those statements the client makes that are expressions of desire, ability, and reason and need to not change, this inversely relates to behavior change. So if change talk moves people towards action and sustained talk holds them back, then the real art of MI is in how we guide the conversation. Not fixing, not persuading, but evoking. Our goal isn't to give the client reasons to change, but to help them hear themselves say what matters to them. We know that advice and coercion can often produce paradoxical effects. In other words, the opposite of what we want. When we say, you need to stop drinking, the typical response is, let me explain to you why that's difficult for me. In other words, we have literally evoked sustained talk rather than change talk. Compare this to an alternative approach, where we use MI to have an intentional conversation with a client where they say, I'm tired of all the trouble drinking causes in my life, and I'm ready to do what it takes to get clean. It's the same sentiment, but where the words come from has a lot of power. Clients are more likely to act on goals that they articulate themselves. So how do we help clients to voice that kind of motivation? Not by pushing, not by directing, but by walking with them. And Miller and Rolnick describe MI using the metaphor of going on a walk. It's not about dragging somebody towards change. It's about joining with them and helping them find their own way forward. When we engage with clients, we might be asking the question, may I walk with you? When we focus with clients, we are asking, where are we going? When we evoke with clients, we're asking, why would we go there? And when we plan with clients, we're asking, how will we get there? Now, if some of these ideas sound familiar, that's because they mirror something else, hope. And that's not by accident. The core processes of MI align closely with hope theory. And I want to take a few moments to discuss hope theory because I think it provides a potentially useful bridge between MI and SRA. Hope is a cognitive motivational process with three components: goals that are clearly identified and anchored to a person's values and priorities, pathways or way power, which are the available strategies to achieve those goals, and agency or willpower, which is the internal drive to pursue pathways towards goals. So first, I'd like to suggest that hope theory offers a potentially useful lens for understanding some suicidal crises. When someone is considering suicide, it's often not because they want to die, it's because they feel trapped, emotionally, situationally, or cognitively. All the perceived exits appear to be blocked, and suicide can appear as a remaining escape pathway that's driven by despair, rage, or apathy. In these moments, it's actually pretty common for clients to describe a sense of hopelessness. And this framework helps us to better define what is meant by that, beyond just a lack of optimism for the future. For many clients, all the components of hope may be breaking down to different degrees. So from this perspective, suicide isn't as much about choosing death as it is about losing sight of other options, of other pathways. So hope theory provides us with a potentially helpful framework for understanding how individuals arrive at a suicidal crisis. But it's also important to recognize that no matter how overwhelming the feelings of hopelessness might be, the very act of engaging in SRA indicates that our client is, at least on some level, ambivalent about dying. And that ambivalence, it's clinically significant. It represents hope, even if fragile. It's a quiet willingness to ask, is there another way to reduce this pain? Is there a path I haven't seen yet? And it's our role to recognize that flicker of hope and to help a client imagine other pathways. And this is where MI really begins to make a lot of sense as a way of doing SRA. MI gives us the tools to sit with distress without reinforcing despair. It helps us foster an approach-oriented mindset, one that acknowledges pain but also makes space for possibility. When used in the context of SRA, MI can support clients in identifying new, life-affirming pathways and regaining a sense of agency. In my opinion, hope theory is a pretty useful way to organize the information we actually gather during an SRA, and also as a way to think about the use of MI in and around the SRA process. In other words, MI helps us have a conversation about hope by shifting from an avoidant to an approach-oriented mindset, validating the distress while eliciting life-affirming pathways, and helping clients to reclaim a sense of control over their cognitive, emotional experiences, evoking desire, ability, reason, and need language around living. So with this perspective, let's take a look at some ways we might map the core tasks of MI to SRA. So to begin, note how the 4 tasks of motivational interviewing map really nicely to existing basic SRA processes. In engagement, we connect with the person, showing empathy for their pain and suffering. In focusing, we suggest an assessment to better understand their distress. In evocation, we build up their life talk, desire, ability, reasons, and need for living. And then in planning, MI can basically be integrated into any disposition decisions like safety plans, outpatient treatment, or even hospitalization. So let's break this down step by step, starting with the first task, engagement, where all meaningful clinical work begins. This isn't just about checking a box before moving into assessment. It's about establishing the kind of connection that makes honest conversation possible at all. When someone is in crisis, trust isn't a luxury, it's a prerequisite. Engagement is the foundation of both effective MI and effective SRA. When someone is in crisis, they're often feeling exposed, overwhelmed, or numb, and they may not easily trust. So our first job isn't to do anything really. It's to be someone who can sit with them in that pain and help them feel understood. The relational stance here is one of deep respect and accurate empathy. Not rushing, not fixing, but simply offering a steady presence. It's where we signal with words, tone, and posture, I'm here, I see you, and I'm not going anywhere. The technical skills at this point are very non-directive and client-centered. Lots of reflective statements that show that we're listening closely and without judgment, open-ended questions that invite the client to share their story, and affirmations that highlight the courage it takes to trust someone with this type of information. When we do this well, we can shift the room. The client may not necessarily feel a whole lot better, but the hope is that they may feel less alone. And that's where hope begins, in connection. Engagement isn't just a first step, it's the tone setter for everything that follows. Here's an example of how reflective listening can be used during this early stage to communicate empathy and build trust. If a client says, I just don't see the point of anything anymore. I feel like I'm just going through the motions and no one really understands what I'm going through. Even when I try to explain to people, they just tell me to cheer up or think positive. In response to this, you might offer a reflection. You're feeling stuck, like you're just existing without a sense of purpose. That must be incredibly painful. You've been trying to express your pain, but the way some people respond makes you feel unheard and alone. Note that this kind of reflection doesn't actually solve anything, but it does connect. It tells the client, you don't have to convince me that it hurts. I believe you. And that's where trust can begin. And this is why the skill of reflective listening matters so much, especially early on during engagement, and especially when that engagement is leading to an SRA. Because in most cases, clients aren't coming in saying, I want to die. They're saying, I'm in pain. And they're watching closely to see how we'll respond. And remember, the primary concern for many clients is actually not their suicidal thoughts or behaviors. It's their psychological suffering. They're not necessarily walking in saying, I'm thinking about ending my life. More often than not, they're saying, I'm exhausted, I'm overwhelmed, nothing seems worth it anymore. And if we jump too quickly into SRA, we risk shifting the focus away from their pain and that can feel dismissive. It can harm trust, especially if the client doesn't yet feel like we understand what they're going through. MI gives us a way to think about what it means to slow down and meet the client where they are. The core skills, open questions, reflections, affirmations, they do more than just build rapport. They communicate something very important. They communicate that I respect what matters to you. I'm listening. And also note that when we lead with empathy and connection, we actually will end up with a more accurate and meaningful SRA because the client feels safer telling us the truth, not just about their risk, but about their pain. And so once we've engaged with the client, the next step is to decide where we're headed. And that's the task of focusing. It's like asking that question again, where are we going? Focusing can look different depending on your practice context and the frameworks you're using. In some cases, MI might be used to introduce the screening and assessment process, helping us to ask for permission and shift the conversation towards safety. Other times, MI principles can be fully integrated throughout the entire SRA process, shaping the tone, pacing, and flow of the assessment itself. This is really seen in models that are collaborative, like CAMS. The key is that focusing isn't a hard pivot. It's a directional shift that keeps the collaboration intact. We're still walking alongside our client, just with a clear destination in mind. MI skills can be really helpful to move the conversation forward. For example, we can use reflections and open questions as simple suicide screening processes. For example, thank you for sharing your story with me. I can see how overwhelming this has been for you. And sometimes, when people are under this kind of stress, they also have thoughts of suicide. And I'm just curious, given everything you've shared with me, have you also been having some thoughts of suicide? Has that also been part of your experience? If the screening is positive, we can continue using MI skills to inform a collaborative transition to SRA. For example, given what you've shared, I'd like for us to take a closer look together. There's an assessment that helps to better understand your situation and think about how to keep you safe. And I believe this can give us a clearer path forward. Would you be willing to go through it with me? So MI skills, especially reflections and questions, fit really naturally into screening conversations. But once we have a positive screen, and perhaps we've also completed a formal SRA process, this is where for many clinicians, there's a temptation to move quickly into discussions around disposition, those decisions about safety, treatment, or hospitalization, and this is understandable. But MI invites us to do something a little different here. When we move directly from SRA to planning, we're skipping an important opportunity. By the end of an assessment, we have learned a lot. We have a clearer picture of the client's crisis, their pain, their internal and external pressures. And in MI, Evocation asks us to slow down for a minute and make use of that understanding with the client before we move into discussion of what comes next for them. This is one of the biggest shifts MI brings to the SRA process. Whether we've used a structured tool like the Columbia Suicide Severity Rating Scale or the collaborative models like CAMS, this moment after assessment is an opportunity to engage in meaningful and intentional dialogue. Instead of jumping straight from risk assessment to planning, Evocation offers an opportunity to hold space and allow a deeper conversation about what we've learned. So by this point in time, we should have a pretty good working understanding of the client's crisis. We have a sense of their psychological pain and the internal distress behind it. And also we have a sense of how these struggles connect to suicidal thoughts and behaviors. We also know this, that they are talking to us and they have trusted us with this information, which again means that they are ambivalent about suicide. But here's the key. SRA helps us to conceptualize the crisis. Evocation invites us to do something useful with that conceptualization. The evocation task in MI gives us a framework for having a purposeful conversation about what we've learned, a conversation that moves beyond just identifying risk and begins to shift the client towards hope. And this is why hope theory can be so useful when thinking about MI in SRA. SRA has helped us understand how hope is breaking down in our client, and MI gives us a tool set and an opportunity to verbally and conversationally start the process of rebuilding hope. So if a client is struggling with intense internal distress, and this has impacted their sense of agency, we can have a conversation that invites them to reconnect to their desires, ability, reasons, and needs for living. Together, these shifts gradually reframe the goal. Instead of an avoidance goal of escaping pain and avoiding suffering, the conversation shifts to help clients explore an approach-oriented goal that's centered on relief and resilience. So how exactly do MI skills help us do this? What exactly are we listening for and evoking in this moment? Again, it might be helpful to think about that metaphor of going on a walk. In the evocation stage, we're essentially asking the question, why might you go on? Why might we go there? This moment gives us a chance to use what we've learned from our assessment, not just to inform planning, but to support a meaningful, values-driven conversation with our client. And as we've already discussed, the key to motivational interviewing is where the words are coming from. I could try to offer life talk to a client, and maybe that does something to help them on some level. But where the power really lies is in the words our clients say. And the evocation stage gives us a space to ask the client to say the words. We want them to verbalize their own life talk. And again, the goal isn't to minimize their pain or ignore their risk. It's to explore their ambivalence. And the truth is that, especially when combined with SRA data, evocation can play a critical role in informing our disposition decisions. When we create space for clients to reflect on their values, strengths, and hopes, we gain insight that goes beyond the assessment forms. And that insight can help shape safer, more person-centered planning and disposition decisions. Now, open questions play a pretty central role during evocation. Basically, you get more of what you ask for when talking to a client. In classic MI, evocation has a directional bend towards change talk. Remember, it's a really unfair football field, and sustained talk doesn't really need our help. And the same applies when evoking with clients who are experiencing suicidal thoughts and behaviors. Only in this case, it might be helpful to think of change talk as life talk and sustained talk as death talk. So, sure, we could evoke death talk. We could talk to them about the disadvantages of living or the advantages of not being here anymore. But after an SRA, we kind of already understand those things, and there's not a lot of value in us eliciting more of that language at this point in the process. Again, the words our clients say have some power, and the idea is to shift the conversation towards life talk and to actually soften death talk. So in evocation, we take a strategic, directional approach. We intentionally guide the conversation towards life talk, which basically boils down to asking for life talk. We ask for the advantages of living and also help them verbalize the disadvantages of dying. So for example, we might intentionally stay away from questions that elicit death talk, like what feels hardest about continuing to live right now? It's actually a great question, but it's inviting the client to verbalize and psychologically connect to their reasons for dying. Instead, a more MI adherent strategy might ask, have there been moments, even small ones, when life felt a little more manageable? What was going on then? Or if you weren't here tomorrow, what would be left unsaid, undone? These kinds of questions invite clients to connect with their values, relationships, and future, and importantly, without minimizing their pain. So just like with change talk, in typical MI, we use open questions to ask for life talk. And as we ask for life talk, we listen with intent to their response. And again, just like with a traditional MI session, we're listening to what's there and reflecting the life talk that we hear. But we're also listening for what's missing and asking for those pieces that haven't yet come into the conversation. And this is where desire, ability, reasons, and need as a framework can be really useful in terms of strategically eliciting life talk from our client. Desire life talk is language that expresses wants or hopes about living. For example, the client says, "I wish things could get better." Ability life talk is language that reflects a belief and capacity to keep living. For example, if a client says, "I've gone through this before." Reason life talk is language that reflects logic statements or sort of reason-based statements in support of living. Like, for example, "My family would be devastated" would be an example of a reason statement. Or need-based life talk is language that reflects urgency or importance to stay alive. For example, if the client says something like, "I have to figure this out." So the idea is that we're listening for all these different elements of life talk and reflecting them, building upon them, encouraging them as they emerge. But we're also listening for what's missing. And if something's missing, the next step is pretty simple. You just ask for it. So for example, if a client says, "I don't really want to die. I just want the pain to stop. My family has already been through so much, and I don't want to put them through more. I know I need to find a way to keep going, but it's just really hard right now." We might notice some very specific life talk in this statement. For example, desire, "I don't want to die," or reasons, "My family's been through so much." There's also evidence of need-based language, "I need to find a way." But what you might notice is that ability language is mostly missing. So we could respond with a reflection that captures the life talk we've heard, but also asks for what's missing. So we might say, "It's important for you to find a way forward, and your family is a big reason for that. Given everything you're facing, what has helped you hold on for this long?" Of course, anyone who's worked with clients in deep crisis knows that life talk isn't always easy to find. When someone's in intense psychological pain, it can feel like life talk is barely there, and it's pretty normal for clients to continually volunteer death-based language. And this is where intentional reflections can come in and be pretty helpful. In these moments, we have to listen almost like detectives, always on the lookout for small, even subtle signals of hope, connection, and hesitation about dying. These signals might be buried in language that sounds hopeless at first, but if we listen closely, we can often find nuggets of life talk that we can reflect and build upon. For example, if a client says, "I don't think anyone would miss me if I were gone. Sure, my kids might be sad for a little while, but they'd get over it. I just feel like they'd be better off if I weren't here." Now, this is a client who is clearly in a lot of pain. They're in a really dark place. But what you might notice is that there's a tiny little nugget of potential life talk buried in this statement. "My kids might be sad." And we can take this and reflect it back to them, making sure that they notice it. For example, we might say, "Your kids are important to you, and you want them to be happy." Another example is if a client says something like, "I've been depressed lately. I keep trying things to help myself feel better, but nothing seems to work, and I'm just not sure how much longer I can take this." A skilled listener might notice a little hint of life talk in this statement. "I keep trying." And we can reflect it, and this example even affirm it, making sure that our client hears their own life talk and that they see their own strength. You're persistent. Even though you've been trying without success so far, you're still looking for ways to push on. You're here, still searching for a way forward, and that persistence says something about you, even if it doesn't feel like it right now. In some cases, our clients might not be giving much to work with in terms of actual language that we're hearing from them, but we can still find creative ways to reflect life talk, even if it's just implied life talk. For example, if a client says, "My life is over. We were just hanging out, and I didn't know my buddies were going to grab that lady's purse, and now the police are saying that I violated my probation. I was going to kill myself earlier tonight. I had the gun, the bullets, everything. I'd rather die than go back to jail." Now, this is a really challenging client statement to respond to. And it may very well be the case that this is someone who needs intensive care. But it's also true that we can use something like a double-sided reflection to listen to their death talk, validate what they're saying with us, and also subtly reframe things by reflecting their behaviors. For example, the thought of going back to jail is terrifying, so much so that you thought about killing yourself, but you didn't. Part of you is still wondering if there might be some other way through this crisis. So, evocation is a powerful way of thinking about the conversation we have between risk assessment and disposition decisions. It's not just about talking for talking's sake. I mean, sure, processing thoughts and feelings with the client is helpful, but evocation really is also a continued form of assessment. As we listen for life talk and we reflect what we hear, we're also learning critical information that can shape our decisions around disposition. When I hear lots of life talk, it's a sign that maybe outpatient care with structured support and a strong safety plan could be appropriate. But when I ask for life talk and there's not much there, that also tells me something important. If I'm listening closely and still not hearing anything to reflect or build on, we may be learning that this client is just barely holding on. And again, this isn't about ignoring risk or minimizing distress. It's about recognizing that what we evoke in this moment helps us make safer, more informed decisions about next steps. Which brings us to the last task in MI, which is planning, or how will we get there? Planning isn't just about imposing disposition decisions. The key is to maintain the spirit of MI during this process. Instead of telling clients what to do, we invite their ideas about what might be helpful for them through this difficult moment. By this point in time with the client, ideally we have shifted the focus from just escaping pain to an approach-oriented perspective of seeking relief and resilience. And it's called motivational interviewing for a reason. If we've been using MI, ideally we've worked to build a sense of agency and willpower around pursuing life-affirming pathways. But motivation alone isn't enough. Clients also need pathways, those specific actionable steps to stay safe. And this is where planning gets more concrete and directive, where we ask, what will you do to stay safe? What next steps will help you find relief? So in summary, motivational interviewing has quite a bit to offer in the SRA process. The emerging literature on this is pretty clear. How we approach these conversations really matters. And MI helps us not only to assess risk, but to strengthen our clients' connection to their care and their sense of agency in the recovery process. It can increase the odds that clients will trust us with their pain and even share information about suicide risk at all. We know that clients who feel heard and involved in the decision-making process are more likely to follow through with our recommendations. MI can help clients to feel more invested in their own safety plans, and clients who participate in decisions around higher levels of care experience better outcomes. MI shifts the conversation from simply not dying to finding ways to live with less suffering and greater resilience. Now, as we mentioned earlier, a big challenge with all of this is that knowing about MI is only the first step. MI isn't just a concept, it's a skill set that requires ongoing practice and refinement. It's one thing to understand the model, but applying MI in high-stakes conversations like SRA requires intentional practice and ongoing learning. So if you're serious about strengthening your MI skills and applying them effectively in SRA, here are some key next steps to think about. First, seek out interactive, skills-based MI workshops in your community. Reading about MI is helpful, and watching webinars about MI can be a good start, but skill development happens in real time. So look for interactive workshops that focus on practicing OARS, refining your evocation skills, and using reflections, especially in challenging conversations. Beyond that, it's also important to engage in ongoing supervision and consultation. MI grows best when it's nurtured through reviewing session recordings to identify strengths and areas for growth, or receiving feedback on the use of MI in high-risk situations, and just general engagement in reflective practice. Finally, it's important to stay curious about emerging practices in this space. MI, especially as it relates to doing SRA, is still an evolving concept. Stay curious about new research, models, and adaptations that can enhance your work, especially in suicide risk assessment. For more on SRA and other topics related to suicide prevention, intervention, and postvention, there are lots of resources available through sprc.org, samhsa.gov, the Action Alliance for Suicide Prevention, the American Foundation for Suicide Prevention, and there are also resources specific to American Indian and Alaskan Native populations that can be found at sprc.org. If you haven't already, I highly recommend subscribing to the SPRC's weekly Spark newsletter. It's a great way to stay informed about emerging research and best practices and resources in suicide prevention. And thank you again for your time. My email is listed on this last slide, and I'm always happy to answer questions and connect with folks. And last but not least, thank you for your dedication to this life-saving work that makes a real difference.